I'd just like to say thanks to all the people that helped us put this together. Damien and I are the poster boys representing this large group of people who helped us design this summit. And I'd particularly like to recognise Janine and Paula, who put these slides together and helped put the data together, and Nora Finn and Alice Stewart, who are the statisticians behind it all, working at the Cancer Council and in the department. So all the credit really needs to go to the team that helped us put this together. Catherine highlighted how we want to reference the optimum care pathways. And while we do that, we'll go through the incidence of prostate cancer in Victoria, talk about the diagnosis and management, and then I'll hand over to Professor Bolton, who'll talk about access to treatment and care patterns and variation across Victoria. So this is a two-part presentation from two of us. The optimum care pathways break down the pathways into these sections, these stages. And today we'll just concentrate on the middle parts, because those are the parts we have the best data on. We're going to use these different data sets to illustrate the variation and the patterns of presentation and care across Victoria, to highlight areas where we might want to concentrate on making improvements. And I'll just call these out, and then we'll go into a bit more detail about what each of these will be able to show. Firstly, there's linked administrative data from the Victorian Cancer Registry, which is the most up-to-date cancer registry in the world. The VAED dataset is a dataset from all Victorian health services, and the Victorian Radiotherapy Minimal Dataset is from all radiotherapy centres in Victoria, and it's linked together to provide a picture of presentation and care across the state. We also have the DHHS Cancer Performance Indicator audit that we will show some data from. And then the other large source of data is the Quality Outcomes Registry, PCOR-VIC, which has now been running for over 11 years and collecting data on men with prostate cancer, diagnosed with prostate cancer on a population basis through Victoria, now capturing 90% of men who are diagnosed. So this shows the slight differences between the different data sets, and what I'd just like to show is the way in which the linked data sets are administrative data sets. They are data sets that consist of data accrued in the department in the Victorian Cancer Registry, and extremely large and powerful, because it includes, as you can see from the numbers, 54,000 patients in the VCR, the Victorian Admitted Episodes dataset, nearly 1 million hospital admissions. When we look at the PCOR-VIC, which is run from Monash University, we have 26,000 patients in the period between 2008 and 2019. Now covers 90% of the population, but it grew over time. The unique thing about the Prostate Cancer Outcomes Registry is that it collects data about the outcomes for men. So we ask about what men care about and how things are for men. We don't ask necessarily the clinicians, or we don't rely on the health administrators to tell us how men have done. We send surveys to the men, and the men report this back in a reliable, validated, standardized survey instrument. So we can tell a lot of detail about how men are coping after prostate cancer diagnosis and treatment. As part of this presentation, we'll also refer to these geographical regions, which are the Integrated Cancer Service regions, or ICS. And there are 8 of them in Victoria, set up in the mid-2000s in order to coordinate improvements in cancer care. So the agencies of the government, set up in these regions. You can see they're abbreviated by, say, RICS or SMICS, and the two ones that will always catch people out are GRICS and GICS. So GRICS is the Gippsland Integrated Cancer Service. So just bear that in mind, these initialisms in mind as we go through the data. So I'm going to speak a bit now about the incidence and the demographics. And as we go through both this data and the data about the mixture of treatment options around the state, we'll talk about both the linked data set and the PCOR data set. And they're just slightly different. So this is a table which shows the detail of the data in both data sets. And both of them, almost 25,000 men, and they very largely overlap. But the PCOR VIC has a slightly younger group of men, and they're in slightly more affluent socioeconomic status. The PCOR VIC is also defined by the way in which we have granular detail about the staging of men that present with prostate cancer. So we know about the PSA, we know about the histopathological grade, and we know about the clinical stage. And you can see the distribution of men there. It turns out that about 8% of men who are initially diagnosed with prostate cancer in Victoria have metastatic disease. And we also, you can see that the grade, which is the differentiation of how aggressive the prostate cancer is in men, is approximately the same in the PCOR data set and the linked data set, except that the PCOR data set is just slightly more aggressive, and that might reflect the way in which our data set goes back a bit further. It's become more common now for men to be diagnosed with lower grade disease, slightly lower grade disease. If we look at the incidence of prostate cancer in Victoria and divide it by the Integrated Cancer Service regions, this is a chart which shows the different integrated cancer services across the bottom and the age standardized rate. So this is a rate which is corrected for the age distribution in each of the integrated cancer services. And it shows there's quite a large variation across the integrated cancer services. And this is something to bear in mind when we're thinking about the differences in the treatment across the state. One of the factors that comes out of this is that if you look at where these integrated cancer services are, there's no real association of higher or lower rates of prostate cancer in regional ICSs compared with the metro ICSs. Another way of looking at or grouping men together to look at the age standardized rate is to look at the socioeconomic status, which we can calculate from their address. And you can see that men who are in the most disadvantaged SES have lower rates of prostate cancer than men in the least disadvantaged. So men who are in affluent groups tend to are diagnosed with high rates of prostate cancer. And one of the things that is critically important during 2020 is the effect of the COVID epidemic on rates of cancer incidence. And we are now looking at a situation where the rates of diagnosis of all cancers is potentially decreasing as people are not presenting to doctors or to hospitals for investigation of potential cancers. So this is almost unique data from the Cancer Council, from Dr. Sue Evans's registry there. And I'll just explain this graph a bit, showing how the notification numbers for prostate cancer have decreased markedly from what we would expect. So the y-axis on the left there is the numbers of pathology notifications on a daily basis. So each dot is a weekday, or is a day in fact. And so each dot plots the number of notifications to the Victorian Cancer Registry each day. So these are separated into the ones that are high at 30 to 40 a day, and the weekend ones are down the bottom, so they're practically 0 a day. The green line represents the expected notification rate. So last year, 2019, there were just over 6,000 men diagnosed with prostate cancer in Victoria. If we plot the daily notifications, so these aren't actually the incident cases, but so these daily notifications are processed to calculate the actual specific number of men, but because many of them are duplicate, or some of them are duplicate, but the Cancer Registry consolidates these and calculates a number per year. But we can see that the notifications have decreased by 25.6% from the expected. So the red line is the locally weighted estimated smoothing. So this is a statistical method for calculating an average of a time series like this, and we can calculate that the rates are down about 26%. So this is a real potential problem that we have to pay attention to as we come out of the COVID epidemic. Part of this is due to the male gender. So this is similar data from the Victorian Cancer Registry, which shows the similar rates for males and females. And what it shows is that the decrease is more marked in males and females. But in fact, it's only about 8% down from the expected in males. And so a lot of the decrease is specific to prostate cancer. The maleness only explains about 8%, or say almost 10% of the difference. A lot of it is obviously reluctance for men to attend the doctors for a diagnostic investigation of prostate cancer. So I'll speak a wee bit about diagnosis and treatment planning. One of the things that's happened in the last 3 to 5 years and right across Australia is the movement of diagnostic technique away from the traditional trus biopsies, transrectal biopsies, to peritoneal biopsies, which provide more information and are safer than the traditional trus biopsies. In fact, the PCOR data shows that now across Australia, transperineal biopsies are more common than trus biopsies. And this graph shows an increase in the transperineal biopsies over time from 2015 to 2018. But it shows that it's unequal and that there's a much quicker uptake of these transperineal biopsies in higher socioeconomic groups and in major cities and compared with regional centres or remote areas. So while the use of transperineal biopsies, better biopsies, is increasing everywhere, it's not spread evenly. Moving on to the differences in socioeconomic group and the histopathology, or the grade or the aggressiveness of the cancer. This table shows in a cross tabulation down the left the different groups of socioeconomic status from 1 to 5. 1 is the most disadvantaged, and then across the top is the range of aggressiveness of prostate cancer, with ISUP group 1 being the least aggressive and ISUP group 5 being the most aggressive. And we've also separated out from the VCR data the men with metastatic disease. And this shows that there's a difference in the aggressiveness of disease in men from lower socioeconomic class compared with the more advantaged groups. And what I've highlighted here is the way in which most disadvantaged groups have markedly higher rates of high-grade disease and metastatic disease than men in the least disadvantaged group. So this is also worth thinking about when Damien talks about the differences in the management of men across the state. And finally, in my section, we concentrated on the optimum care pathways and recommending that men who are diagnosed with prostate cancer attend both urologists and radiation oncologists when they have localized disease, or at least talked about it in a multidisciplinary team meeting, so they have the opportunity to have their case discussed by a wide variety of specialist groups, including nurses and medical oncologists, as well as radiation oncologists and urologists, and social workers and physiotherapists. Everyone has their own specialist area where they can contribute to the care of the men. And the Department of Optimum Care Pathways and the ICSs all are working to increase the proportion of men who are diagnosed with prostate cancer who are discussed in multidisciplinary clinics. And this graph shows on the left-hand side the percentage of men who are discussed in the MDT in the different X regions, and it's broken up by campus. So you can see that that in NEMICS, for example, almost 100% in this sample were discussed, even across the different health services within or hospitals within NEMICS. But there is variation there. You can see that one health service, one hospital in NEMICS has very little discussion of men. And you can see there's quite a lot of variation across the different X's in terms of where the cases are discussed in multidisciplinary clinics. So this is in fact improving over the last prostate cancer summit, but it's not yet there yet, and there's a lot of variation across the different hospitals within each X. Damien will take over now, and he will talk about the variation in the treatment.
So leading on from what Jeremy has said, some of the different metrics that we've looked at are as follows. Firstly, primary amongst these is the incidence of radical prostatectomy within 1 year of diagnosis. And this would serve as a surrogate of the availability of prostate cancer surgical treatment, and secondly, as an identification that people were being diagnosed at a time where treatment was able to be provided and they had not already progressed to metastatic disease, or perhaps did not have disease that was insignificant and need not have been diagnosed at an early time. So you can see, whilst there are varying peaks and troughs across the networks, peaking at 47% for Barwon Southwest in 2017, and the lowest being at 23% for Gippsland in 2015, there tends to be a fairly constant range between 28 and 42% across all of the different integrated cancer service networks. So some consistency of the data is apparent even over the 5 years that have been assessed. What is different though is the annual prostatectomy volume. And you can see how in these two slides we have this great disparity between what is provided to the patients treated in the public system versus those treated through the private hospital system, with the public sector accounting for only 30% of radical prostatectomies and the private sector accounting for 70%. 19 public hospitals undertook radical prostatectomy, and you can see that there are 3 that undertake more than 50 per year, and then a range that undertake between 50 and 20 with this long tail. And similarly for the private hospitals, we have now 5 undertaking well in excess of 100, 2 undertaking around 100, and several more indeed extending out to that range between 20 and 50 over the course of the year. But you can see there's a substantial bias towards this procedure being available to patients in the private hospital as opposed to the public sector. And I would contend that a significant component of this is the availability of surgical robotic therapy in the private sector, to which even uninsured patients will default for treatment. Part of that is demonstrated in this slide, where you can see the patient flow for radical prostatectomies that are undertaken within 1 year of diagnosis. These represent patients with non-metastatic prostate cancer. So you can see if a patient was diagnosed and treated for their prostate cancer in the same integrated cancer service that they lived, you would have a linear graph line down the diagonal of the slide here. But for sake of example, if you look at northeastern Melbourne, only 53% of those men who live in this sector are treated within this sector, with 38% of them devolving to the western and central sector of the city, where the greater technology prevalence is apparent. That tends to be a bit less as you go down further away from Melbourne. Only 63% of men in the southern Melbourne area are treated locally, with 26% devolving to central Melbourne. For that Western Central Integrated Cancer Service, 78% are treated locally. Barwon, which does have access to robotics, will have 79% treated locally. But for those patients such as Lord and Malik, then it's down at about 1/3 of patients treated for their prostate cancer in the integrated cancer service that is their residence. We see a similar patient flow for radical radiation, but there's more consistency here, with usually somewhere around 70 to 80% of patients being treated in the integrated cancer service that is their primary place of residence. There's some variations for the Hume region, but nonetheless, the vast majority of patients are able to receive treatment at a place that should, in theory, be convenient for them to do so. Most people will find this slide also to be somewhat counterintuitive, that where we're looking at those patients with organ-confined prostate cancer at a level where the majority of them will warrant treatment, you'll see that there's this consistently high level of men having radical prostatectomy, somewhere between 35 and 49% of those men. The radiation treatment tends to vary somewhat in intuitive manner. As the frequency of radical prostatectomy reduces, so does the frequency of radical radiation therapy increase. Small numbers of men have chemotherapy to begin with. We would presume that these are men who might have oligometastatic disease. And then there are those substantial groups, again, having no active treatment or active surveillance alone, ranging, again, reproducibly between 38 and 49%. So there is some disparity in the equally effective treatment options, depending upon the integrated cancer service network, but this is particularly marked in association with the availability of brachytherapy, which tends to influence the choice of radical radiation more positively, and then consequently have a lower reduction or reduction in the number of patients treated by radical prostatectomy. We also see substantial variation in surgery type and hospital type based on the integrated cancer service of residence. So if, again, we'll look at the patients who live close to the centre of Melbourne, those in the southern Melbourne, northeast Melbourne, and the western central area of Melbourne, very few of them are having radical prostatectomy that is not undertaken robotically. Some tendency for those in southern Melbourne to do so at a greater rate than the rest, but in general, at least around 50% of patients having their surgery undertaken in private robotically. There is a small number of patients who have their public robot done either in the public and private arrangements, or through Peter MacCallum or Royal Melbourne in the central Melbourne area that do have access to robotic technology. But the majority of those patients who are public and being treated in the public system are being treated with open radical prostatectomy surgery. The exception to this is in Barwon Health, where there is robotic access for all men in the public system who would seem to warrant it. There we have a greater percentage of men in public that are having public open surgery, 19% versus 6%, and presumably that's a reflection of surgical candidate suitability for robotic surgery as opposed to availability of this resource. Still, nonetheless, we have the majority of men being treated in private with robotic surgery. For the more regional networks, this again tends to flatten out to some extent. There are those men who will come to the city for either robotic surgery in central Melbourne or through the public and private partnership that's available through St Vincent's and the Austin, but significant numbers of men again coming to the city for private robotic surgery as well, in spite of their rural integrated cancer service of residents. What is most apparent, though, is the higher prevalence of treatment by open robotic surgery by socioeconomic status. So for the public sector patients, you can see, again, we have the majority of them being treated by open surgery regardless of their socioeconomic status, but at much lower numbers. But for those men who are in the higher socioeconomic groups and being treated in the private sector, the rate and volume of radical prostatectomy, particularly open radical prostatectomy surgery, is substantial and sits really at multiples of 4 and 5 times what we see in the private sector at its zenith. The higher you go up the socioeconomic status in the private sector, the more likely you are to be treated by surgery and to receive treatment by robotic surgery as opposed to open surgery. And indeed, we see a similar variation here when we look at these numbers by integrated cancer service of treatment, that where people live closer to the city in what one might assume to be the wealthier areas, the socioeconomic status tends to represent much higher likelihood of treatment in the private sector and treatment by radical prostatectomy as opposed to other forms of treatment. That's reflecting, as Alan White said before, a greater ease of dealing with the financial pressures of being diagnosed with cancer surgery if you're in a higher socioeconomic status group. Finally, we'll just look at the last remaining slides that look at non-surgical treatment. If we look at treatment trends within the modalities of hyperfractionation, we see that the intermediate risk group patients tend to have more in the way of short course radiation therapy as our time has passed, indicating the greater availability of this sort of treatment. And similarly, although it's less prevalent for those patients with high risk prostate cancer, there's been a trend for them to receive short course hyperfractionation rather than long course as well over time. I think this, as Jeremy would know, is based on a series of studies that came out around 2016, probably reflecting the greater awareness of these studies since that point. And we see a similar thing here as well with regard to treatment trends with docetaxel in metastatic hormone-sensitive prostate cancer over time, that over the intervening period, we've seen a greater utility of docetaxel-containing therapies as opposed to androgen deprivation treatment alone, again, representing the influence and greater acceptance and uptake of the data identified in CHARTED and other studies. Again, similarly, we see this for men under 70 and men aged over 70. Perhaps the trend is less substantive for those older men, but for men under 70, the vast majority of them now, where they have metastatic hormone-sensitive prostate cancer, appropriately receiving docetaxel-containing therapies as opposed to androgen deprivation therapy alone. So what could we conclude from this? Firstly, we do have great data here that's available for assessment. And whilst we've obtained snapshots of it today that seem particularly relevant to us, there is more in the way of data that is available from these remarkable data resources. And access to this data and the expertise of the data manager means that we can now measure and manage the variations in care and appropriately try and point out where patients potentially could be managed in a more standard of care fashion. We do have notable variations, however. Firstly, in information and support at diagnosis and treatment planning, primarily through access to multidisciplinary meeting discussion, which tends to vary substantially based on the integrated cancer service of someone's residence. We have access variations for prostatectomy by socioeconomic status and by geography, and that's particularly pertinent with regard to minimally invasive treatments that would assist early return to work and reduce post-operative complication, primarily being robotic as opposed to laparoscopic surgery. We have marked variations in surgical volumes, and as people would know, this is a pet interest of mine. Where you have an operation being done in a hospital where it's done more frequently, you'll have more educated staff that are more likely to be aware of subtle variations in treatment and in outcome, staff on the ward who'll be more attuned to what is or is not normal for the patient, and presumably also better access to multidisciplinary meetings, to ancillary services such as physiotherapy, and to prostate cancer nurses and counselling. We also have significant variations in access to radiation with particular reference to brachytherapy as a balance to surgery and radiation therapy.
Last time at the diagnosis and treatment patterns for men with prostate cancer, and this time we are going to go through a survey of what happens once men have been diagnosed and managed, and what happens afterwards. So the 5 areas of this presentation are to remind us of what happened at the last summit and to give a quick overview of the events and the projects and the plans and the progress that we've made since the last summit, and in order, I think, to try and stimulate interest and activity in the work that will arise out of this summit. And then I'll go on to talk about differences in survival and hints that we might have about reasons for differences in survival in different regions of Victoria, and ask for some reflections about what we can do about this. I'll talk about the supportive care activities that have come out of the last summit and are ongoing at the moment. I'll talk about unmet needs for men with prostate cancer, and then I'll talk about differences in the geographic patterns of quality of life after treatment from the Prostate Cancer Outcomes Registry. So what happened after the 2016 summit? We had 3 large-scale projects that, or aims that came out of the last summit in March or April of 2016. The first one was to, having seen the data that came out of the Prostate Cancer Outcomes Registry, was to encourage all healthcare providers to contribute to the Prostate Cancer Outcomes Registry, and for the Prostate Cancer Outcomes Registry to share the findings from the registry with the local clinical groups, and I'll show you some data about that. There's also a recognised need to improve community awareness and GP implementation of the NHMRC testing guidelines, the PSA, and I'll show you some data about that and what the VICs have managed along with the primary healthcare networks to do about that. And finally, we wanted to try and address the quality of life issues for men after diagnosis with prostate cancer through a coordinated approach using existing and integrated models of care. I'll show you some of the work that's come out of that, and obviously some work that we still need to do, because We've heard today, for example, of the continuing needs that men have after diagnosis of prostate cancer. This is a histogram or stacked bar graph, really, of the incidence of prostate cancer and the proportion of men on the prostate cancer outcomes registry. So the y-axis is the number of men, and along the bottom are the years. And the total number that you can see in 2009 is for example, the incidence of prostate cancer. It was over 5,300 or so in 2009. And then you can see that it decreased over the period of time to just over 4,000 by 2014. And then you can see it slowly and steadily increasing to 2018, when it was over 5,000 again. The Victorian Cancer Registry has just published the figures for 2019, which show now over 6,000 men, just over 6,000 men were diagnosed in 2019. So that's a reflection in a way of increasing use of PSA since 2014, 2015, because the rate of diagnosis is directly proportional to the number of PSA blood tests done. The bars, though, are also divided by the proportion of men who are in the prostate cancer outcomes registry. So the important one is in a way, everything except the bar on top, everything except the sort of beige bar. And what that shows is over the period of time, and this is shown across the top of the diagram in our percentages, is that over time we've had increasing participation in the prostate cancer outcomes registry. And you can see that the summit last time was actually effective, because the proportion of men contributing to the registry has increased from around just over 2/3 to over 3/4. And in fact, in 2019, it was almost, and now it's almost 90%. So the prostate cancer outcomes registry has grown in size and proportion of the men diagnosed, and it's happened since the last prostate cancer summit. So you can take some credit for helping achieve that outcome. The prostate cancer outcomes registry is a fantastic resource, and it's just a single example of the way in which we're able to monitor in the prostate cancer outcomes registry the patterns of care, for example, in this example for men with prostate cancer. So these graphs represent different risk groups, which is data that you can only get from the prostate cancer outcomes registry, showing the change in the patterns over years. So you can see that, for example, in low-risk men, there's been a persistent increase in proportion of men who are treated with active surveillance. It's increased from just under 60% to now almost 80% in 2018, the last year in which we have figures. And again, you can see lots of changes in pattern there, and this is a direct result of the way that the prostate cancer outcomes registry can offer timely information about the patterns of care, for example. But in the last part of the section, I'll also show you some fantastic information about the outcomes that men experience. So this is another example of the work that arose out of the last prostate cancer summit. The VICS, Victorian Integrated Cancer Services, worked with the primary health networks to produce a range of resources for GPs, and these are examples of these. They include videos and education materials. Now, an interesting thing about this is that there was a considerable amount of work done, but tracking the using Google Analytics, tracking the downloads. These videos haven't been used as much as we would like, and there's obviously this is obviously reflected in some of the words we heard about use of PSA and experience of men. There's obviously more work to do. Similarly, at the Cancer Council, we worked with the University of Melbourne to provide e-learning modules for GPs and health professionals regarding referral pathways and PSA testing for prostate cancer. The X groups also did work to improve the supportive care needs. So that was one of the other aims that came out of the Prostate Cancer Summit. The X had a program of sexual health education, support group involvement, and local projects. I know that many of the consumers on this conference today were involved in this work. They were also involved in supporting a project called True North, and also stimulated a project called Bro Support, and work on unmet needs, and I'll talk about that in a moment. So the True North project was a project run by PCOR Vic, and we looked at ways in which we could use the registry to identify men who were having more problems with prostate cancer side effects after treatment, and linking them with a prostate cancer nurse care coordinator to ask them more questions about their problems, and then to provide access to supportive care areas that they didn't have access to previously, to provide them advice about that. And we looked at the outcomes of this and looked at the ongoing follow-up and results, and found that the men who were in that group were 60% less likely to report large problems with sexual function, for example, compared with the historical control group who had treatment prior to the advent of True North. So this was a way of using the prostate cancer outcomes, reported outcomes from patients, to target the support. In a way, we've built on that with Bro Support, and I'll talk a wee bit about this. Bro Support is a project which is run as a partnership. It's run by PCOR Vic. It's funded by VHA and Movember, and this is building on the experience of the True North project to provide a scalable mechanism to provide support. The idea is that we'll develop a portal, a web-based access that will allow men to compare their outcomes, their side effects with men like them, and to gain access to information and help should they think they require it. This has been going on for just under a year now, with a co-design process where we're working with men and clinicians and patients and the team to design what this should look like, to look at what men really worry about, and to have that conversation with clinicians from all disciplines, and with the team to design a concept of a web interface and a portal that allows comparisons with a model of outcomes that they would expect using data from the Prostate Cancer Outcomes Registry. And we've just now had the go-ahead to start building that, and we'll do that in January or February and run a pilot early next year. So one of the things that I'll encourage people to do is to just watch out for this, because it's a way of, on a very large scale, using the internet, providing support for men who might be having trouble after prostate cancer. So we talked last time about where the data comes from. I'll just remind everyone, there's essentially two large sources. There's the linked data set, which is a linked group of 3 different data sets within the Department of Health, and also coming from the Victorian Cancer Registry. And there's the Prostate Cancer Outcomes Registry at Monash, which is run now by Nathan, inspired by Sue, and I helped Sue start this up in 2008. So this, the PCOR Vic, is a outcomes quality registry, and we ask men about their experience and their side effects after management of prostate cancer. So we have direct contact with the men, and we have their views on how things have gone. The administrative data set is is all men with prostate cancer, and it's data reported to the department. So they have a large number of patients. You can see the numbers there, and it's very, very detailed data about management patterns. And whilst they're about the same size, 2014 to 18, 23,000 men in the LINC data set, and in PQOL-VIC, 25,000 men over the last 10 years. They're slightly different. They are pretty much the same men with minor differences. So that allows us to look at survival outcomes. And this is data from the Victorian Cancer Registry showing how the relative survival for men with prostate cancer at 5 years varies across the different integrated cancer services. So you can see there the highest rates relative survival seen in SMICS, over 96% at 5 years, whereas lower rates are seen in the regional integrated cancer services. Now, one thing I should just point out here is that the scale on the bottom, of course, doesn't include 0. This is a very compressed scale. So whilst it looks as though these regions are a long way apart, this is all within a range of less than 10%. And so whilst there are real differences there, they're not necessarily as large as you might see just looking at that graph. And that's important because there are lots of different reasons why we might see these variations in outcome. And it's very important if we want to improve the long-term survival and outcomes for guys with prostate cancer, that we identify the right reasons and attack the right reasons. And this is data from the LINC data set, just showing, for example, how different the men are in the different regions. So, for example, this is a cross tabulation of ISUP group is the grade or the aggressiveness of prostate cancer, and 1 is not aggressive, and 5 is very aggressive, and metastatic disease is obviously disease which has a relative poor survival. And down the left-hand side of the screen are the different integrated cancer services. And what you can see is that if you, for example, are a man diagnosed in the Grampians, then 15% of those men have high-grade disease, compared with only half that number in, say, SMICS. And that by itself will mean that the men who are diagnosed in the Grampians have a worse outcome. So we can see that we can't attribute all of the difference in the survival rates to anything to do with treatment necessarily. It has something to do with the men themselves and the later diagnosis, perhaps. So the next thing I want to talk about was supportive care needs and unmet needs. And we, at the department and the VICS level, we have been encouraging the use of these screening tools. And these are surveys showing the uptake of the screening tool in the health services. And we can see that at the time the survey was done, the target was 50%. And most of the health services in the States were not there at that time. The target's even higher now, and you can see there's large variations, and it doesn't look as though there's a huge uptake of these screening tools. And this is perhaps reflective of the way in which some of the problems faced by men are not recognised. The Victorian department has done a survey of healthcare experience of cancer patients in Victoria in 2019. And I show you this data just to provide some sort of context for some of the other data I'll show later on about the unmet needs for men with prostate cancer. So this was a survey done of patients, just under 1,000 patients with a good spread amongst surgery, radiotherapy, and chemotherapy. And what they saw was that actually there were the vast majority of patients had overall positive responses. So that's an important thing to recognise, because whilst there are obviously gaps, in an overall sense, people are pretty positive about the experience of cancer care. When they drill down to prostate cancer, there are many areas where prostate cancer had a even more positive response than other forms of cancer. So, in fact, in prostate cancer, 81% were informed about how to manage ongoing symptoms or side effects. 85% were positive about the communication with health professionals. So, while I can show you some data, and we've heard stories about where things aren't so good, in general, there are many good things about the way that we look after men with prostate cancer. These are the regions that definitely in that survey we found that there were reasons or areas to improve. Financial areas, lack of information in some men, and also that men responded they weren't asked about their support needs and the need for information. Building on that, or going alongside that, was a departmental desire to find out about unmet needs. And the Victorian Cancer Outcomes Registry, PQAL-VIC, has the advantage for the department in that we are in contact with men 12 months after treatment. So we did a project with the department to look at unmet needs using a survey of survivor unmet needs 12 months after treatment. So the idea was to find out what these unmet needs might be. And the survey instrument that we used was this short form survivor unmet needs survey, which is 30 items that men are asked about, including questions in each of these 4 domains. And this is the sort of thing that it asks. It asks about, for example, finding information about complementary alternative therapies, and men are asked to circle an answer. This is a scale, and men respond to these sort of questions. So it's 30 questions, and these are the items which showed a high or very high unmet needs in prostate cancer patients. And not surprisingly, for the high or very high, the highest unmet need was finding car parking. And that's always a problem that comes up in any survey of unmet needs in cancer care. But you can see there's a lot of financial and emotional things which that a large number of men are not satisfied with, or not getting help with. Now, another way of trying to look at the problems of men after the diagnosis of prostate cancer is to use the PQAL-VIC to look at the side effects, the quality of life of men after diagnosis. We send a form, or ask men to fill out a form on the internet, which is called an EPIC. And the EPIC 26 has 26 questions that ask about questions that break down into these 5 different domains: the degree of urinary incontinence, the irritation, sexual function, bowel function, and hormone function. And this then allows us to look at the extent of problems that men have. Now, we can geomap these. So we've done a big bit of work with the Victorian Cancer, or the Australian Cancer Survival Centre, to look at how these differences in side effects are distributed across the geography. We can obviously look at them in detail. So we can look at, say, for example, sexual function and find areas in Victoria where there's men with a lot of problems with sexual function, similarly bowel function and urinary function. But to give an overall assessment, we've developed a composite EPIC score, which is made up of a combination of all of those domains. And so we get a score from essentially 1 to 20, where 20 is no problems at all. Everything's good in every one of those domains, and 5 is everything's bad in every one of those domains. If you do that and you combine those scores for men a year after treatment for prostate cancer from the registry, this is the distribution of the scores that you get. So most men are about 15, so not doing too badly, but there's obviously a group of men down at the left-hand side of that graph who are having problems. And we used a cutoff of 10, and we looked at the proportion of men in each geographic location that had a score less than 10. So this is picking out geography which has high proportions of men with high proportions of problems with prostate cancer symptoms and side effects. And this is how it all turns out. So this is the colored graph, and the scale is on the legend is on the right of the graph. So green is good, a low proportion of men with lots of problems, and orange and red is high. And you can see that there's definitely regions of Victoria where we have high and low levels of problems with side effects after prostate cancer treatment and management. And drilling down just into the metro area, there's a lot of green there. So there's areas where we're not seeing too much in the way of problems, but there's definitely areas where there's a much higher proportion of men who are having problems. Now, this work done with the Peter Mac Australian Cancer Survival Group, done by Nathan and the team at Monash and the team at the Peter Mac. And we're continuing to work on this to understand the pockets of problems with side effects after prostate cancer management. And this is a sort of composite, so we can drill down to look at areas where there's more problems, for example, with rectal function or urinary function. So this is a very rich data set, and we're working with the people of the Peter Mac to look at these geographic regions and think about how we can intervene to provide help there. So just to summarize all of that, we've shown you that the survival across Victoria for prostate cancer or from prostate cancer varies considerably, but the variation is related as much to the differences in the aggressiveness and the stage of prostate cancer at diagnosis, as well as presumably by variations in treatment. We've showed that there's variations in the way that needs are identified and how we address the needs of men with prostate cancer. And these are particularly problematic in the non sort of, as doctors would say, the mainstream cancer areas of outcomes. You know, when there's lots of unrecognized needs in emotional care, financial advice, and fatigue management. And finally, I've showed you the use of the Prostate Cancer Outcomes Registry and how that can provide insight into where there's geographic pockets of need across the state that we might address with interventions. So this is a slide which shows, bringing it all together really. It shows the different things we've found over the last 2 weeks. It's just reminding you about the variations that we saw in last week for those who weren't here, and to remind those who were here. And it adds in the variations that we've seen this week. There's a cast of thousands, and I'd particularly like to thank Damien for co-chairing with me. I'm the poster boy, but Damien's the brains behind the operation, or half of the brains behind the operation. The Nora and Ella were the super brains behind the operation. They were the pair that pulled a lot of these statistics together. But Nathan Papa with the P Corp pulled a lot of these stats together. And finally, Janine and Paula were the people in the VIX team who put all the slides together and corralled all of the working party members who are listed there. So thanks to everyone for this. And of course, everyone there.